Good afternoon. Guess what time it is? It's top of the hour. That's 4 o'clock p.m. in the mountain time. Means 6 o'clock on the East Coast and 3 on the West. And there is only one place that you need to be right now, and that is right here. Fertility with Fink and Friends. I am Fink. You are friends, and it is great to be here as we are every Tuesday evening at this time. Thanks for being here, everybody, on this 4th of July week. And it is so awesome to see all of you here. As I am fond of saying, this is really my favorite place. It's the best time to be here. So to be together with this group of people really just makes me happy. And it is all about my happiness. So if there was any question about that, I just wanted to kind of try to make it clear, Fink and Friends is the name of the show, and we are here to talk about. Oh, can you hear me? Let's see if that's any better. People said they couldn't hear me there. Oh man, I said the whole thing and you missed it there. So I guess I'll say it again. It's 3 minutes after the hour now. This is Fertility with Fink and Friends. I am Fink and you are friends. And here we are, as we are every Tuesday evening, live from Colorado Springs. I'm Dr. Randy Fink, and it is a pleasure to be with all the great people who join me every Tuesday. And if you are new to our time together, thanks so much for being here. And if you are an old standard with me here, then thanks so much for sticking by, especially on this 4th of July week, where we have the opportunity to say thanks to our great nation for giving us such a wonderful place to live. And what we do here is talk about things that are important to us. And that is, sometimes it's things about life. It is often things about fertility. We take the time to answer your questions as best as we can, and also to just kind of snuggle up together and talk about those things that are all on our minds. So let's see who we've got going on here. First on the Facebook side is Neri Mill. Hi, Neri. Thanks for being here. We've got my Instagram feed right here. Number one today is Libby K1216. Thanks so much for being number one here with me. Laura Marie Boss, Ceciliana Melissa, great to see you here. Miss Emirati, thank you for being here. This fine Tuesday. A special hello to Brandis Montez, who is our wonderful nurse practitioner here at CNY Colorado. I try to get Brandis to come be on the show with me here sometimes, but she's just too important for the rest of us. So Steph Honey 24, I like that name. Hi Skittles, good to see you today. Kelsey Sass, let's see, Chop, and I can't quite see it and I can't get it fast enough. So hi, thanks for being here. A special hello to the Bama Gal, which is none other than Mrs. Emily Fink and her beautiful husband, Harold, also known as my mother and father, cavelling away there in lower Alabama. Staley is with us from Miami. Thanks for being here, Staley. Let's see who we have over here. Let's see. We also have, we've got the Facebook and the YouTube and the LinkedIn folks here in the middle. And on CNY's Instagram, it looks like April Crump is the first to join, along with Shy Daj. If I said it right, sorry if I didn't. Adrian Lynn, Ali Dins, nice to see you. Stephanie Abarca, thanks for being here. Dee's Pages, Get Fit Health Style, I like the name. Just Bryson, thanks for being here this afternoon. All these folks were telling me that they couldn't hear me. There was a problem with the mic there, so sorry about that. Hi to Sexy Mary. Shay, nice to see you here as well. And yes, now we are back with some audio here. Okay, let's start here with some questions if we can. And here, oh, by the way, if you didn't notice, I'm sporting a new pair of glasses here, trying to change up the look. But how about this? Maybe today we're going to do something crazy, and we're going to do this without glasses. What do you think? I'm like, I feel a little blind, but changes up the look. Got to keep it real. Okay. CS Garza says, I have a question. I had an HSG in 2022 that said my tubes were blocked. During my ultrasounds, they saw fluid, which they think were my tubes were filled with fluid. The recommendation is to take out the tubes, and that is correct. So what you have there is that those tubes, when they are inflamed, can create some fluid on the inside, and really what we would call that is inflammatory fluid. And that fluid is what's known as a hydrosalpinx. Hydro is fluid, salpinx means the tube. And when you have a hydrosalpinx, that fluid in the tube can become toxic to an embryo. So we don't want to just leave that tube there. That's a recommendation then that we take that tube out, that we remove it. If it's on both sides, we should remove both fallopian tubes, because when you go to place an embryo inside the uterus, and then that fluid has a way of being able to wash back into the uterus. It can be toxic. It can kill the embryo. So really, it would be negligent for us to put an embryo inside of you if we knew that you had a hydrosalpinx present. And so that's the rationale for removing the tubes. Now, many general gynecologists will say, well, wow, I don't really get that. It sort of goes against my grain to think about removing fallopian tubes for fertility purposes, because the fallopian tubes are a necessary part of fertility, but not if you've done IVF. If we've done IVF, then we've circled our way around those fallopian tubes and we are not using them at all. So there's the rationale. Hi to Storm 718212, must be from New York, 43 with an AMH of 0.22. I have a consultation on September the 11th. Can't wait. I hope I can use my own eggs. We can always try with your own eggs. So that's one of the differences that is associated with CNY compared to many, if not even most other IVF practices. We will absolutely try because why not? Who am I to say whether your eggs are going to work? Now, the low AMH number. The low AMH is what we call diminished ovarian reserve. And what diminished ovarian reserve tells me is that, well, okay, so we know that we are born with all the eggs that we will ever have in the ovaries. And over time, as we mature, we start to lose those eggs, either from ovulating them or just the eggs kind of decay and start to go away, to the point where by the time we're 35, we are losing about 50,000 eggs. I'm sorry, that's really not right. I was being overly dramatic. We're losing about 10,000 eggs a month. Okay, we'll say 50,000. We're losing 50,000 eggs every 5 months. Okay, so 10,000 eggs a month. Now, even with a low AMH, that still says there's probably thousands of eggs left in the ovaries, but are we going to be able to access them? What the lower AMH tells me is that your response, your predicted response to medication, is going to be lower than that of someone with a higher AMH. So it really just means when that number is roughly less than 1, that we're going to have to work really extra hard in order to get you to produce eggs. But the second problem we have there, Storm, is that by 43, those eggs have been there since, for 43 plus years since you were in utero. And over time, that DNA starts to become less stable. So with less stable genetic material combined with fewer number of eggs, it becomes harder and harder for us to get pregnant as we mature. And that's really what's going on with why it gets more difficult to get pregnant as we age. But can we do it? Can it happen? Absolutely, it can happen. And I always try to think of it as optimistically as possible rather than to say, oh, this probably isn't going to work. Well, you know what? It's an uphill battle. And as long as we recognize that it's an uphill battle, then the possibility is definitely there. What is a mini IVF? This comes from Better with a Bet. What is a mini IVF? Mini IVF is referring to a lower dose of medication. So technically, what does that mean? Well, if you had, for example, a low AMH, the classic wisdom with lower ovarian reserve was to say, well, let's pour as much medication as we can on your ovaries to try to get them to respond. Well, what we learned from that is that those very high doses of medication may not really be a better option. Why is that? Because the ovaries, once you pass a certain point of stimulation, higher dosing does not get you better results. You start to get diminishing returns. And so, what that means is that you increase your dose, which also means you increase your price, but your results start going that way. So instead of results going up, you've got results going down while medication is going up. So, what they learned really from the European experience, which was where, well, so in Europe, the governments cover many, in most places, cover the IVF, but the government tells you this is the dose that you're going to use for IVF because they're paying for it. This is what they're going to do, and so they use a very low dose. They don't care if you're getting 20 eggs or you're getting 2 eggs. They're telling you the dose that you're going to have to use, and so with those very low doses, what we've learned is that a mini dose gets you really about the same kind of response as you would expect to get with the very high dose, although sometimes even better, and at a lower exposure to medication, which means at a lower cost, which also means with a lower side effect profile. So that in general is a good thing. So we will often start with a mini dose at CNY. Our feeling is that less is more. So I always feel like it's appropriate to consider an age appropriate dose. And that's usually where I go first. There are some folks who will say, no, we're always going to start with a mini dose. And it really kind of depends on the provider you talk to, because there are differing opinions on that. And so, I think that's definitely worth a question. But what is a mini IVF? It's the same IVF, it's just using a low dose of stimulation. All right. Hopefully that helps you there better with a bet. Question on tubes. Let's see. That's CS Garza. We just answered that one. What are some causes of a chemical pregnancy from Denise Bean? There's really two things. So, a chemical pregnancy, we've got two kinds of pregnancies that we think about. There is a clinical pregnancy, and that's when you have that positive pregnancy test, and the pregnancy grows to the point where we can look with an ultrasound and we can see it inside the uterine cavity. How do we do that? We do that typically with vaginal ultrasound. So by the time your HCG level, your beta, is 1500, by the time it's, well, we'll call it really between 1500 and 2000, we expect that we should be able to do a vaginal ultrasound and see the pregnancy inside the uterus, also what's called an IUP, or an intrauterine pregnancy. Okay, well, if your beta is 2500, and we look with the ultrasound and we cannot confirm an intrauterine pregnancy, then our presumption is that that may be an ectopic pregnancy, a pregnancy that's not inside the uterus, and then we have to really treat it as such. But a chemical pregnancy is where you have that positive beta, it starts to go up, but it's before the point at which we can see anything by ultrasound. And when that happens, oftentimes it goes up and then it starts to go down. That's what we think of as a chemical pregnancy or a biochemical pregnancy. There are the classic wisdom there is that happens as a result of a chromosomal issue with the embryo, that it is an embryo factor unless proven otherwise. And I think that is true the first time it happens. If it happens multiple times, then I start to think, well, this may be an autoimmune issue. This may be a problem with the uterus and the way it's trying to accept the embryo. Is there something about your immune system that's trying to prevent that pregnancy from implanting? That's the reason that we use Prograf. Prograf is a medication that is designed to stop the body from rejecting a pregnancy. So every time the embryo implants, inside the endometrium in the uterine lining, it creates a little wound. And just like any other wound on your body, the immune system reacts to that wound. Well, we want to tell it, calm down, you can react to it, but this is supposed to be here. It's not a foreign invader. It's not like a splinter in your thumb. And that's what the Prograf is for. So folks with recurrent biochemical pregnancies, we start thinking about recurrent implantation failure, same kind of problem, that it may be an autoimmune issue. And that is one of the reasons that we will use the medication tacrolimus or Prograf. And to that point, Molly Maroney says, getting ready for a transfer in early August. When do I start the Prograf? Prograf is started, if you're doing a medicated cycle, Prograf is started with the progesterone. If you are doing a natural or a modified natural cycle, it started when you do your trigger or when you ovulate, if it's a fully natural cycle. Okay, Shay, that's the one with a JZ on the end. Shay Daz, sorry about mispronouncing. What is the right level of estradiol, progesterone, and LH to start a stim? So when we do baselines, which would be baseline lab tests and ultrasounds, what we're looking for is to know that your hormone levels are at the beginning of your cycle. So LH still may be a little elevated from the last cycle, but we're looking at it for it to be generally less than 5. But there's no rule there that's a requirement. Estradiol, typically we want to see kind of around 50 or so as a baseline level, but certainly less than 100. When that estradiol is greater than 100, it suggests that your body is making some estrogen someplace, and that may interfere with your stim medications for IVF. Progesterone is usually going to be less than 1. When progesterone is above a 2, we start thinking that you have ovulated. Now, it still may be higher progesterone from the prior month when you ovulated, but if that number is a little higher, then usually we repeat it again to see that it is in fact going down instead of going up. Laura Marie Boss says, for your patients, you put on low-dose naltrexone. How soon before the egg retrieval do you take them off so it doesn't interfere with anesthesia? Do you titrate down? No, you can just stop low-dose naltrexone outright, kind of right away. And usually we stop it typically at the time of trigger. And then it shouldn't interfere. A special shout out and hello to Alexis Lorente in Miami, who is a wonderful nurse practitioner that operates the facility currently, but in the way formerly known as the Miami Center of Excellence. It's a great place to monitor your IVF if you're in South Florida, but also for women's health. Please talk to us about how to reach Alexis. Hi to Michelle Marks. Shabnam says, Wednesday is my beta. Hopefully I get a positive. And if next egg retrieval, I'm coming to see you in Colorado. We would love to have you in Colorado, but I hope that you will be positive there. Hayden Natalie, a special hello also to Zaneda, to amazing Javier, and lovely Onyx says, what's your take on vaginal birth for IVF pregnancies, or does it always have to be a C-section? Absolutely, positively not. Does it have to be a C-section? So really a C-section, you can choose to have a C-section as a mode of delivery. And, 20 years ago, you couldn't. It would be, really heresy for you to say, I want to have a C-section. Now, every day of the week, people do a C-section birth by choice. So you can choose to have an elective cesarean section. But as far as what's medically necessary, and there may be a bunch of different reasons you would choose that, but for what's medically necessary, there is no reason in general that you can't have a vaginal delivery with a C-section, only for obstetric indications, like if there's some concern about the baby, or otherwise some reason where you would need to have a C-section. But yes, absolutely, a vaginal delivery is okay. Can Provera cause menopause? How to reverse its impact? How to get a period back? So no, Provera does not cause menopause. Provera is a progesterone, and oftentimes we will give you some progesterone in order to induce your period. And in this situation, she has stopped her Provera about 30 days ago and didn't get a period. What that tells me is that there is likely, so one of two things: either you didn't absorb it correctly, but depends on how long you were taking it. Sometimes we'll use that progesterone in oil because we know it gets absorbed directly there. But in order to get a period, After stopping progesterone, it means that you have to have enough estrogen in your body to have grown a lining. So that suggests to me that maybe, just maybe, there was an estrogen issue as well. Let's say hello to all our friends over here on Facebook, and let's see what we got going on. Okay, Neri says, what's your opinion about getting Nubigen wash before frozen transfer, as well as an endometrial scratch? Is it a good choice for a more receptive lining? So, let's talk about that endometrial scratch. What does that mean? It sounds so barbaric, an endometrial scratch. The endometrial scratch is basically an endometrial biopsy. It's usually where we place a little straw on the inside, suck a little piece of tissue out. And in so doing, it creates a little injury in the lining of the uterus that is supposed to result in an immune response in that lining of the uterus that then helps to rebuild some of that lining and improve the odds of conception or of pregnancy. In fact, as they've studied an endometrial scratch, it does not make any difference at all. So if you call me, and I get a lot of people who call me on the phone and say, well, I read on the internet about this endometrial scratch, and don't you think I should be doing that? Because I want to do everything. Well, we all want you to get pregnant, but I don't want you to have to do things that are unnecessary. So when they studied an endometrial scratch, they found that no, actually it really doesn't make any difference in the positive pregnancy tests. So it was an older thing that was done. It used to be something that was done sometimes as a last ditch effort. We might try to offer it to see if we can get the body to do something that it wasn't otherwise doing. But in general, it would not be considered a standard of care. A Nubigen wash I consider important for Nubigen can actually really help growing the lining of the uterus. And so I think of it for that. I think of it for people who have hard to resolve chronic endometritis or a chronic inflammation in the lining of the uterus. I think the PRP wash is a great thing for people who have had recurrent pregnancy loss, recurrent implantation failure. And I really honestly think everybody should be doing an HCG wash because it does improve the receptivity of that uterine lining. Let's see. Hi to Valerie and to Lynn. Liz Fisher says, happy Tuesday. I'm gearing up for my first FET and plan to do an HCG wash. See, what good segue there, Liz. Awesome. How soon before the FET is the wash done? Also wanting to do intralipids. Would that be done at the same day and time? Yes. Usually the intralipid infusion is done as on the same day as the wash. Typically it's done ideally we like to do it 2 days before transfer. We say anywhere from 1 to 3 days before. 2 days, I think, is really the sweet spot. I will say that there are some folks who have read about where you do a little mini HCG wash at the time of embryo transfer. I do not recommend that. We have seen poorer results with pregnancy. So despite what many people have read on the internet, it is not something that I would recommend you do. Hi to Lisa. I had my first egg retrieval last week, and I have 3 day 5 or 6 embryos. Awesome. So 3 blastocysts, hoping for 2 more tomorrow. I had 5 fertilized eggs, but 3 were late. Since I fertilized late, do you think maybe it would be more than a day? Well, so it depends on, so here's what happens with eggs in the lab. They fertilize, we've got the eggs, they look at the eggs and they try to ICSI them, which is to take, as long as the egg is mature, they take a sperm and they place it inside the egg. Well, the next day they go and they look, and there are some specific criteria they look for to tell you that that egg has fertilized. Sometimes they don't see that it's fertilized, but as long as the subject under the microscope there still looks alive, it's not discarded. They'll go back and look at it the next day. Why is that? Because in some cases, it may just fertilize late, but there may also be a situation where from the embryologist, from looking at it, may not, they may miss the window of implantation that they're looking for to see that it has fertilized. And that's what we call a late fertilizer. And that means that it has fertilized. What does that mean for outcomes? Well, it's still a good embryo. Do they perform less well than others? Some say that's the case, but again, it's hard to know if that's a problem with, well, it's just because of the time that we looked at the embryo, it just didn't appear to be fertilized, or did it actually fertilize late? So yes, I think Lisa is the answer to your question. And Frida says for patients with premature luteinization, what can be done? What protocol to use? Would it compromise the transfer? Well, Frida, I'm not exactly sure what you mean about premature luteinization. Some people have what's known as a luteal phase defect. And that's where there is an issue in the lining of the uterus in the second half of the cycle. And that's something that we can actually fix pretty well with progesterone. And that's one of the reasons that people might be doing IVF, or why sometimes people are getting extra progesterone. Let's see here. I think Kelsha is her name. Me and my partner are doing a frozen embryo transfer using donor eggs. We have a 6-egg package. We only want 1, maybe 2 kids. Will 6 eggs be enough, or should we get more? She just did her baseline tentative retrieval on the 17th in Syracuse. Is there a difference between that center and Colorado as far as success, thinking about transferring embryos there, and you guys do the transfer? Okay, so you got 2 questions here. First of all, donor egg. Donor egg is where you are selecting an egg donor and using literally a donor egg with either known sperm, known donor sperm, or anonymous donor sperm. So you're creating an embryo using the genetic material that comes from someone else. That's not always an easy decision to make, but there's something I want to point out about a donor egg. The first thing is, when you create an embryo using a donor egg, the number one thing I hear from folks is, well, I don't want to feel like I'm carrying someone else's baby. Well, I want you to think of this. Every drop of blood, every milliliter of fluid in that baby that's inside your body comes from you. There is no question that that's your baby. Well, now we also know about something that's called epigenetics. And epigenetics tells us that there are a series of little switches that can be a million of them, let's say, turned on or off in whatever order is programmed by the environment in which that embryo grows, which means your uterus. So those things will program very important things inside the embryo. So this goes back to the nature versus nurture thing. Yes, the eye color is going to be programmed by the genetics. The hair color, the skin tone, that's going to be genetics. But is that child going to be mechanical or artistic? Is your baby going to color with crayons or markers? Will your child sing as a bass or as a soprano? These questions really are probably programmed by what order those switches are on or off, depending on the environment of the uterus. So it makes great credence to the argument that that's your baby. Yep, eye color may come from something programmed in the genes, but so much of what happens in that baby that comes from a donor egg has to do with the environment in which it grows. And now there is science to back that up. So that said, a 6-egg package. Well, the first thing you have to know is that the survival rate of thawing an egg is always going to be less than the survival rate of thawing an embryo. So an embryo is a little functioning factory, right? An embryo will have about a 97% survival rate when you go to thaw it. So it's not 100%, but 97% is pretty good. Eggs are just one cell. They're one little cell in the body. And they will have a survival rate of generally quoted about 80% or so. So if you purchase 6 eggs, it is unlikely, it's possible, but I will say that there's a reasonable probability that all 6 of those eggs will not survive the thaw. But if they do, there's also a reasonable probability that all 6 of those eggs will not fertilize. So I would start with that group of 6. I do not recommend that you say, well, we just want to be sure, so we're going to purchase 12 and do them all the time, because in that scenario, you're making a lot more. You're probably going to make a lot more embryos really than you need, and I wouldn't, encourage that. So I think 6 is a great place to start, and you can always make a decision, what to do after that. As far as success rates across the board, our facilities are generally the same. So there is some difference with between Syracuse and in Colorado and Albany and Buffalo and Sarasota. That difference probably has to do some with the aesthetic of the office. What does the office look like? It has to do a little bit of difference in the personalities who work there. It has to do with the number of providers that are available and who will actually be taking care of you. These are generally preference things. Sometimes you pick a location because they're just easier to get to, and so that preference may not be important to you. But as far as success rates across the board, CNY is generally pretty consistent with success rates that we have to offer. So do I think you'll do any better by shipping an embryo from Syracuse to CNY, or rather to Colorado? No, I don't think you'll do any better. You'll incur more cost. I think Colorado is a very lovely place to visit, and I happen to like the providers who work here. But do you have a higher chance of that, a higher success rate doing that in one location versus the other? I would say no. I wouldn't make a decision based on that, because we are pretty consistent. Hi to Midgie, and thanks for the compliment on the new frames. I appreciate that. I also want to say a special shout out to the best nurse practitioner in Minnesota, whose name I don't see on here, but she says she's there, and she often says she's here, but I don't see the name. So hello to you, and thank you for being here this fine day. Hey, it's it's 34 minutes after the hour, so let's take a little break here and talk about a couple of other things before we jump back into questions. 4th of July, I hope you're going to be doing something fun for the 4th of July. Yes, we are open on the 4th of July. It's a half day, so we are doing retrievals and transfers. I believe there is also basic monitoring happening in all of our facilities on the 4th of July. So it's a great day for celebrating, for being with family, for being with loved ones, but it's also a great day to kind of still be involved with CNY, because we are here for you. I want to mention that I know it's been a hard week for some people. I've had some friends who have been through some very difficult things this week. Some have lost loved ones this week. Some of my friends have had to say goodbye to part of their fur family, their fur kids, fur babies, as you might call them. And that's always a very terrible and hard decision to have to make. But what I want you to know is that we as a family stand here together, no matter who you are or where you are or what kind of hard time you're having. You are not alone. This group of people is here to support you. Certainly, it's easy to say that we're here to support you through the fertility world, but this is an incredibly supportive group, and no matter what kind of problems you have, you are not alone. And my heart goes out and heartfelt sympathies to all those who have lost loved ones, be they family members or or pets this week, because tough things to go through, tough times, especially while other folks are celebrating things like the 4th of July. What else did I want to talk about? I wanted to mention a little something about egg freezing, because this is a question that I've gotten several times by email this week, and that is, how many eggs do you think I really need to have? And there is a defined answer to this. It's not really just an opinion, although I have plenty of opinions. How many eggs do you really need? Well, so when you're doing egg freezing, what you're doing is that you're kind of purchasing a fertility insurance policy, right? It may be that you never have to use those eggs. There's no reason, after freezing eggs, that you can't get pregnant in the natural, normal way, and those eggs don't have to do anything. But in case you end up needing them, they sure are nice to have. I'll bet you there are a lot of folks who are listening to this broadcast this afternoon who would say, "Gosh, I wish I had frozen eggs, when I was 25 or 26 or 28." 100%. How many eggs do you need? There is a calculator that we can use, and it comes from a website that's called MD Calc, MDCALC, MD Calc. So if you go to go to Google and Google MD Calc egg freezing, or egg freezing calculator. That will bring you to a site where, if you put in your age at the time that you're doing some egg freezing, and you put in the number of eggs that you could theoretically get, or after you've done your cycle, the number of eggs that you have, it will tell you the probability of being able to achieve one live birth, so basically one kid, 2 kids, or even 3 kids from that number of eggs. And so that gives you some real objective guidance about how many eggs you might want. That's pertaining to egg freezing. It's built in, a number is built in there because we know that all those eggs will not survive a thaw. But you can also use that for IVF and say, all right, well, if I am 38 years old and I get 6 eggs, even though I'm not really freezing the eggs, I'm planning to fertilize them and do something with them, what's the probability that I'm going to get a live birth, or 2 live births, or 3 live births from that? And that's MD Calc, MDCALC. MD Calc egg freezing is what you Google, and that'll take you to that site, and that actually provides some very useful information. All right, we got a little bit more than 20 minutes here, so let's jump back in and see what we can answer. Okay, Callie is here. Excited for my first FET in 2 weeks with you guys. I'll be on the Immune 3 protocol. Is Neupogen a shot or just a wash? I would if you're doing immune level 3, I would recommend the Neupogen shot. The Neupogen wash kind of has a specific indication. I don't think it's needed for the general public, for the general kind of population. So Neupogen as a shot, 60 milligrams, will bring up your white blood cell count. That's what it's supposed to do. It brings it up, sometimes actually very high, so that people who aren't expecting to see that are surprised by it, but that's its job. That's what it's supposed to do. Neupogen 60 milligrams is part of the immune protocol level 3. What causes an ectopic pregnancy? And this comes from Fiona. That is a very good question. And to answer that question, I'm going to bring in a special guest here, my little pink uterus. She's very sweet, but she joins me on a lot of our shows here so that I can demonstrate some things. So hi there. Nice to see you all. So little pink uterus, what causes an ectopic pregnancy? All right, so how does pregnancy actually occur? Pregnancy occurs when sperm, okay, here's my visual of sperm swimming. Sperm swims inside. Sperm gets in here. Ovaries, which are out here, release an egg. The egg is taken up by the fallopian tube and goes into that fallopian tube. Sperm swims inside, swims through an opening on the inside, called the tubal ostia. The tubal ostia is the opening on the inside of the uterus to that fallopian tube. The sperm swims down here. That is where sperm and egg meet, right there in the fallopian tube. So when we're doing IVF, sperm and egg are meeting where? They're meeting in the laboratory. They're meeting in a dish. So we don't have anything to have to do with the fallopian tubes, right? But in nature, sperm and egg are meeting here in the fallopian tube. But you can imagine if there were some obstacles in along that roadway. Let's say there was some scar tissue. Let's say that there was some inflammation. Let's say that some little bump in there made that embryo stop moving, because once sperm meets egg and creates the embryo, it is eventually going to float its way down the fallopian tube into the uterine cavity. And that's where it takes up residence, and that's where it grows. Well, what happens if that embryo doesn't make it through? What happens if it hits a roadblock in there and it gets stuck? The embryo probably doesn't know that it's stuck. It knows that, well, okay, I'm just going to keep growing every day. It's adding more and more cells. It's metabolizing. It's starting to grow. But it's growing inside the fallopian tube instead of the uterus. It can't continue to grow in the tube, because eventually what's going to happen is that tube, the ectopic is going to grow so large that it is probably going to burst open, which is a ruptured ectopic pregnancy. And that is something that people can bleed to death from. So it is frowned upon. In the fertility world here, we try to recognize and really diagnose that intrauterine pregnancy as early as is possible, because ectopic pregnancies are more common in an infertility population. So that said, we want to know that that pregnancy is actually inside the uterus. In IVF, an ectopic pregnancy can still occur, but it only occurs about 1% of the time. And how does that happen? Because we're placing that embryo inside the uterine cavity. How does it make its way up into the fallopian tube? Well, there are some little hair cells that are called cilia. That's a little visual for you there as well. It's kind of making me dizzy. Those cilia typically move the pregnancy along the fallopian tube until it pushes it into the uterine cavity. Well, what happens if something's wrong with those cilia, and instead of pushing out, it may pull them in? Just like that embryo can float around inside the uterine cavity, it can float its way into the tubal ostia and up into the fallopian tube. And that's why 1 out of 100 IVF pregnancies will or embryo transfers can result in an ectopic. So that's what causes an ectopic. Michaela says, I graduated CNY last week after our transfer. Congratulations. That is awesome. Tiffany says, thoughts about Depo-Lupron for treatment of adenomyosis in preparation for an FET cycle. Lupron is a big gun. What Lupron does is that it literally pulls the plug on your hormones. It puts you into a temporary menopause. And what that will do is that will suppress some of the glandular tissue that is adenomyosis. So what is adenomyosis? Well, we know inside the uterine cavity there is a glandular lining. And that glandular lining sits inside a bunch of muscle. The job of the muscle is to squeeze the baby out when that time comes. The glandular lining is designed to function as the world's best baby blanket, right? So that's where the embryo goes. It's like a little bassinet in there. So we place an embryo inside, or that embryo floats its way in nature and implants in the baby blanket, where then it grows. Well, adenomyosis is where part of that baby blanket actually grows into the muscle. And as that happens, it means that both the muscle can function abnormally, or there can be also dysfunction in that glandular lining. So Lupron, which induces a temporary menopause, can be used to treat endometriosis. It can be used to treat adenomyosis, and it is the big gun. There are also oral medications that we can use for both of those problems. That's one called Oralissa and one called Myfembry. They are both reasonable options if we know that you have adenomyosis. If we know that you have endometriosis, I recommend for sure that we suppress some of that hormonal function before you do an embryo transfer. Adenomyosis can also be part of a normal variant that women as we age, and I say we as humans, not I don't have a uterus myself, but as humans age, adenomyosis may be a normal variant in a uterus. It does not necessarily mean that there's something wrong. It is not necessarily pathological. So just because an ultrasound or something shows evidence of slight adenomyosis does not mean that I would necessarily jump to treat you before you did an embryo transfer. So hopefully that is helpful there. What would be your recommendation for ovulation induction if Clomid and letrozole hasn't worked? Well, at that point, we move on to doing the injectables, which are called gonadotropins, and that is Gonal-F and Follistim. Now, if you're doing simple ovulation induction for things like home intercourse or for an IUI, I don't recommend, honestly, that you move to the injectable medications for several reasons. The first is, well, they're really expensive. And if you're going to spend that much money on medication, I would strongly suggest that you do a treatment that has a very high probability of getting you pregnant. Home intercourse or timed intercourse or even an IUI, they're methods, they're things that we can do, but they are not very high probabilities of pregnancy. So if you're going to spend all the money for the injectable medication, I would say go to IVF. I think that's a much more cost-effective decision based on the fact that each embryo you make has a dramatically higher probability of getting you pregnant than does something like even an IUI. So given what you're spending on the injectable medication, I think IVF is the better bet. The other concern is that when you use, even low dose of the injectable medications, the goal with these medications in doing IVF is that we are trying to get you to make as many eggs as we can get from you so that we maximize the odds of you being able to get pregnant. Well, if you make a whole bunch of eggs, a normal semen analysis, a sperm count, the minimum normal is 15 million. It may take an army of sperm to get that one sperm to the point where it can fertilize an egg. But I don't want to be putting 15 million sperm into someone who has just ovulated 4 or 5 eggs, because that is how we end up with disasters, right? We want you to have one healthy baby at a time. We don't want you to have twins. We certainly don't want you to have triplets or any higher order multiple gestations. So that's another reason why the injectable medication is really not the best choice just for simple ovulation induction. Hi, Ashley Novak. Nice to see you today. Let's see. Shaydaz says, handsome and wonderful both ways, with or without glasses. Thank you very much. I appreciate that. Mish Mark says, for stims, some of the meds are to be taken in the evening. I'm a night shift nurse. Are those directions still applicable to my opposite sleep schedule? Yes, they are. Yes, they certainly are. Chop says, I am on your mini protocol with Clomid and letrozole. You mentioned putting me on progesterone and estrase right before the retrieval, but I don't see it. Can I ask for those to be added? Well, I would say, send a message in and ask them to ask me so that I can look at your chart and we'll figure out exactly what we want to do. So usually what I try to do, if I didn't put it in there, I apologize. But what I try to do is I like to give folks some estrogen and progesterone in the cycle right before they start their IVF. Maybe like day 21 or so of the cycle before your stim start. and just 7 to 10 days of some estrogen and progesterone. And that does a bunch of things. One, it helps to coordinate the growth of the eggs in your ovary. It helps to synchronize them so that hopefully they'll all kind of grow at the same time. It also sort of helps to juice up the ovaries. It increases the blood flow that's going to the ovaries that really is going to be needed to carry those hormones there to get you an ideal response. And lastly, it sensitizes the brain, the portion of the brain that's going to be producing those hormones. So I think that's important. And so, yeah, if I didn't put that into your protocol and I meant to, yeah, just send a portal message in and say, can you please ask Dr. Fink? He mentioned the estrogen and progesterone priming is what I'll call it, 7 to 10 days before starting. Katie Camp, is that the real Katie Camp? I don't know if you're still watching here. Katie Camp, I've known for, oh my gosh, 25 years. One of my old time young, she's not old. I'm old. She's not. I think I started seeing you probably when you're about 14 years old. Golly. Equestrian is here. Is Receptiva necessary before the first transfer if I've had a history of loss? Receptiva website says you can't do it during retrieval, but you said otherwise. Okay, so Receptiva is a non-invasive test for which is designed to test for the presence of the marker associated with endometriosis. So it used to be that endometriosis we could only diagnose by doing a laparoscopy. A laparoscopy is a surgery under general anesthesia where we place a little camera through your belly button in order to look inside and try to find endometriosis. That used to be the only way we could do this. Receptiva is a non-invasive test. It's a little endometrial biopsy. Put a straw in, suck a little piece of tissue out, and it tests for a marker that's known as BCL6. This test is supposed to be, it is FDA labeled to be performed 7 to 10 days after ovulation. So doing a natural cycle, that means you test when you're when you have a positive ovulation predictor, and then you go into your doctor's office, have the test done. This can be done any place. It does not have to be done at one of our facilities. Your own doctor can perform the test. I think it's a great test. It really hasn't been studied in the general population to say, is it useful for taking every woman to see if she has endometriosis, silent endometriosis. Can it be used in that way? If the endometriosis hasn't affected you, then you might say, well, do I really need to test for it? Because it's not an inexpensive test. But then again, if you're positive, then you kind of want to know about it because it may, actually have an effect on you being able to get pregnant there. It hasn't been studied. So do I advocate it in some circumstances? Yes, even if you haven't had an unsuccessful embryo transfer. It is, as I said, the FDA labeling is that it's done 7 to 10 days after ovulation because that's about the time that your embryo would be implanting. So what you want to know, are you expressing this BCL6 marker at the time of implantation? They are studying it to see, can it be done? Is it valid? Or I should say, what is its validity at other times during the cycle? So personally speaking, based upon some advice I received by some of the folks who were involved in actually inventing this test, and many others in the field of infertility, it can be performed outside its guided window. Because the thought is, well, if you're expressing BCL6, you'll probably be expressing it even if it's 7 days before, or about the time that we were otherwise, going to be doing your egg retrieval. So many people think that, well, why don't you just do it during your egg retrieval while you're under some anesthesia? Then you don't have to feel it. And if it's positive, it's positive. Now, if it's negative, then you ask yourself, well, would it be positive if we tested it a week later? They are studying that. Eventually, there will be some guidance with that. But at this point, many people would opt to say, well, I'd rather just go ahead and do it and get it done because if it's positive, then it's positive. with the understanding that it's being done outside the FDA labeling that is said to do it 7 to 10 days after ovulation. If you have diminished ovarian reserve, does that automatically mean you will go into menopause earlier than normal? No, it doesn't actually. So that AMH test doesn't say anything about when you're going to go into menopause, because you can have a very low number and still have eggs and follicles in the ovaries that are secreting estrogen. So menopause happens when you stop making that estrogen, and the average age for menopause in the United States is 51.4. Nor does having a low AMH tell you that you can or cannot have a baby, because there are plenty of people who have a low AMH who get pregnant without having any problem at all, doing it on their own. Really, all it says is that you are going to have a more challenging response to stimulation medication, particularly with fertility treatment. So you absolutely can still get pregnant on your own. You can, and nor does it say anything about when you're going to go into menopause. So how do we use that test? How would your general gynecologist, let's say you're going to go for your checkup, I would say I think having an AMH level, John, is a very important thing to know, because let's say that you're 30 years old. You are in a relationship, but it may not be the relationship that you believe that you want forever, or that you intend to have children with. But you say, well, gosh, doc, I'd like to do that AMH. And so she draws the blood test for you, and it comes back and it's much lower than expected for your age. What does that say? Well, what that would say to me is that's a good indicator to think about freezing eggs, because as that number goes down, it means that if you wanted to do treatment later on, we know we would have a harder and harder time in getting your ovaries to respond to that medication. So it may be a better thing to get your eggs as early as possible, i.e. now. And then you've got an insurance policy, and then you really just don't have to worry about it so much anymore. That's, I think, the best use. And I really do think that every woman should know her AMH. In fact, I think maybe I'm going to do my next Instagram post should be about that. Do you know your AMH? Because damn it, you should. And if you don't, ask your doc. If they don't know how to interpret the number for you, call us. We're happy to talk to you about that, because AMH is very important. Let's see. Natalie Foster says, can you tell me thoughts on next steps? We used a donor egg with a husband's sperm. We got 2 out of 6 day 3 embryos. Advice on next steps. Okay, so you've got a couple of day 3 embryos that come from donor eggs, and that is awesome, because those donor eggs are, they come from young, healthy people, which means that there's a good probability that they can get you pregnant. So I think it depends on how many kids would you like to have, Natalie, and that's really where the question lies. Because you've got a couple of embryos. Yeah, they're day 3 embryos, so we don't really know what they're going to do. We don't know if they'll survive. We don't know if they would otherwise grow out. If you tested them, would they be normal? We don't know. But what can you do? If you wanted to transfer those embryos, there's a reasonable probability that you may end up pregnant. Let's say that you transferred one and you didn't get pregnant, and then you came back and you did the other and you did get pregnant. Well, at that point, it's realistically going to be probably 1.5 to 2 years before you can do another round of IVF. And 2 years from now, you may have a very different situation in terms of egg quality or AMH. So if you would be happy with that one baby, go ahead and do the transfer now. If your hope was, well, you really wanted to have 3 kids, then I would say you want to bank up as many embryos as you can, as soon as you can, so that it maximizes your number of options. We got a couple more minutes left here. Shan Turcott says, just had a double embryo transfer yesterday in Buffalo. Have a bit of a cold today. What do you think about HCG boosters? HCG boosters are useful if you did a natural or a modified natural embryo transfer, FET. If you have done a medicated cycle, HCG boosters do not improve the outcomes. So I don't think that they're necessary in that regard. But with the natural cycle, HCG makes more progesterone in your body. And so, yep, it is a good thing. Emily Wynn says, hi, Dr. Fink, second transfer, first FET yesterday. Fingers crossed there, my friend. Alice in Wonderland. Love the name. Thank you. Hi, Dina. Thanks for being here. And Nancy, Florida girl. Sexy Mary says, I should be having my donor egg transfer in August, and my school is asking me to get a COVID vaccine for this year. Is this okay? Yes, the evidence shows that COVID vaccine, whatever you may think of it politically, there has been no evidence to suggest that it is harmful for pregnancy, and in fact is protective over pregnancy, because being pregnant and contracting COVID significantly increase risks both to mom and baby. C. Cummings says, does COVID negatively affect a retrieval? Day 8 post-COVID, supposed to have baselines tomorrow. Should I just prime another month? Okay, so in my opinion, I would say yes. I would prime another month if you can, because I do believe, based on seeing my own friends right here in this office who having seen their ovaries and knowing that they have usually tons of follicles, getting COVID, seeing a significant decrease in the number of follicles in the ovary. And then as that COVID resolved, looking and seeing that the ovaries appear to be much healthier with many more follicles and ultimately a much better response to stimulation. I do think that you should wait. Is there any good evidence to that? It's based on my own experience, but to me, it just makes sense. COVID does some strange things. Let's see. Jenny Gilby, day 3 embryos versus day 5, had 2 failed transfers with day 3s. If you grow out to day 5 or to blastocyst, you're going to get an embryo that has a higher probability of being able to get you pregnant. But if you're limited in the number, sometimes it's better to have an embryo just to place back inside, because then it's in you. Now, so it would be useful, Jenny, to know, are your embryos going to grow to day 5, which says that, well, they're probably better quality embryos and more likely to be normal. Gosh, we had so many good questions today, and I didn't even get to nearly, half of them. So I sure am sorry if I couldn't answer your questions here. But we're about out of time for today. We'll be back next week. By the way, next week we'll have a special guest. I am Fink, you are friends, but the friend coming in the studio here is going to be Ryan Rolla, who is one of our anesthetists here in the Colorado Springs office, and we'll be able to give you some helpful tips and information, teach you a little bit about the anesthesia that goes along with the fertility process. So hopefully that'll be something of interest to you next Tuesday, same time. So until we come back, have a wonderful and happy 4th of July. Every day forward with kindness, because the world is not a kind enough place. And I hope it brings you some little iota of pleasure to know that you are being kind to someone and that someone appreciates that. Every day forward with love, and every day is a new sunrise. Every day is a new beginning. Every day is a new adventure in hope. Because this whole damn thing that we're talking about here is not the book of your life. It is only a chapter. And what are we doing? We are rewriting it. So until next week, again, thanks so much for being here. Dr. Randy Fink from Colorado Springs. Good night.